what are the scope of homeopathy and what are the limitations we are facing in COPD cases. To recap homeopathic therapeutics of COPD, I will explain certain medicines which will be more important and which make glimpses of few therapeutics of COPD. And I will, at the end, I will discuss a case which was a very significant case of my practice, and as we will discuss that case at the end. As an introduction, the chronic obstructive pulmonary disease is a major cause of chronic morbidity and mortality throughout the world. As everyone knows, COPD is one of the major cause of morbidity. COPD is currently the third leading cause of death in the world. So it is the third leading cause of death according to the WHO. These are the top 10 global causes of death, out of which COPD comes at the third level. So top 10, out of top 10 deaths, around six are from non-communicable disease and 3 from communicable disease, and 1 is due to the road injury. The most common death usually happens due to the ischemic heart disease. Second one is stroke, and third comes the chronic obstructive pulmonary disease. Even the lower respiratory infections comes next to the COPD only. That is the importance of COPD. That is why I take this subject for the presentation. And there are so many cases of COPD and which causes the morbidity and mortality of the individuals. In India also, so there are so many cases, and the cases are increasing day by day. So what is the definition? WHO. Chronic obstructive pulmonary disease is a lung disease characterized by chronic obstruction of lung airflow that interferes with the normal breathing and is not fully reversible. That part is important. Last part is important. It is not fully reversible. In asthma, usually we get the reversible condition of the lung ailment, but in COPD, that is not reversible. It is a chronic obstructive pulmonary disease. It's a lung disease characterized by chronic obstruction of lung airflow that interferes with the normal breathing and is not fully reversible. That is the definition of WHO. And there is a organization, Global Initiative of Chronic Obstructive Lung Disease, that is called GOLD. GOLD controls the COPD respiratory complaints, especially the COPD. They are formulating the guidelines throughout the world, and they are the definition of GOLD. According to 2019, they are usually changing the definitions as per the current scenario. In 2019, they are given the definition for COPD COPD is a common, preventable, and treatable disease that is characterized by a persistent respiratory symptoms and airflow limitation that is due to airway or alveolar abnormalities. Airway or alveolar abnormalities is important because airway obstruction can be due to the bronchitis, and alveolar abnormality is more significant in emphysemas, usually caused by significant exposure to noxious particles or gases. That is the definition by GOLD in 2019. What are the main risk factors of COPD? The major risk factors of COPD are tobacco smoking. That is the main cause. Around 80 to 90% of the COPD is due to the tobacco smoking. The second is indoor air pollution, such as biomass fuel used for cooking and heating. That is very important. In Indian scenario, it is important because in India, in household activity or in the cooking purposes, biomass fuel is used. Usually, wood, dried cow dungs, crop residues are used for the cooking. And also heating. What do you mean by heating? Heating is during winter season. So it's these wood and all are used for heating in the villages and all, and that produces pollution, and that is one of the cause for the risk for the COPD. Outdoor air pollution usually from sulfur dioxide and particulates. Sulfur dioxide usually from the vehicular pollution, and particulates usually from industrial pollution. And this usually particulates are the main main risk factor in the industries and polluted countries. Occupational dust and chemicals, usually vapors, irritants, and fumes, are also that also causes the COPD as an occupational disease, especially in the industries, and also those who are working in factories and all. They are more exposed to the vapors, irritants, and fumes. Other risk factors of COPD are the first one is age. Usually COPD develops after the age of 40. So the COPD symptoms rarely we get before this age. But in certain cases, COPD appears in the childhood itself. If in the those children who born very early, or premature babies with respiratory infections, they also develop the COPD. Respiratory infections, especially, what is the main respiratory infection which leads to COPD? So usually the recurrent attacks of the influenza is the main cause. So seasonal flus that triggers the COPD, and also the pneumonia and other infections, respiratory infections triggers COPD. Socioeconomic status, low and middle income group. Why is low and middle income group? So this is because they are of the lower strata or middle strata. They are not having that much approach to the healthcare facility. They are having economically, they are weak, and they are living in such conditions. So they are more exposed to the dust and fumes, and they are working in the factories, and they are the laborers, and they are more prone to exposed to the dust, smokes, and particulates and all. And so usually it affects this low and middle income group individuals more. Then the last one is alpha-1 antitrypsin deficiency. This is the genetic deficiency. Usually, even though it is a genetic deficiency, the symptoms starts appearing after 40s only. And also, it is more common among the cigarette smokers. If this deficiency is there and the person is smoking more, then the symptoms appear very fast. So around 3% of the COPD cases are due to alpha-1 antitrypsin deficiency. So these are the risk factors of COPD. Then, according to WHO, the WHO has find out certain key points regarding COPD that is important. So these things we must know while practicing. The main points are the global burden of a disease study reports a prevalence of 251 million. That means around 25.1 crore cases of COPD globally. That means cases are there globally. Globally, it is estimated that 3.17 million deaths are caused by this disease, 5% of all deaths. More than 90% of COPD deaths occur in low and middle income countries. So usually, I already told that usually it affects the low and middle income group, and also the majority of the countries with the maximum number of COPD are the middle and low income countries. India is one among them. Then COPD is likely to increase in coming years due to the higher smoking prevalence and aging populations in many countries. Because of the healthcare facilities, the more aged population are prevalent among the developed countries and also in the developing countries. So the COPD is the morbidity COPD is more prevalent in those countries. And also the smoking is increasing, and that also causes the COPD more. Many cases of COPD are preventable by avoidance or early cessation of smoking. Smoking is the main causative factor. So the cessation of smoking will reduce the prevalence or that can be prevented. COPD is not curable, but treatment can relieve symptoms, improve quality of life, and reduce the risk of death. So it is not a curable disease, but it can be treated. We can relieve the symptoms and improve the quality of the life. Then what is the scenario? What is the burden, COPD burden in India? So what in India, the COPD is the second most common lung disorder after pulmonary tuberculosis. The main cause of lung disease is pulmonary TB. After that, COPD is the major pulmonary disease seen in India. Estimates suggest that there are 3 crore COPD patients in India. That is a very large number. So it comes around 12% of total global COPD cases. Male to female or smoker to non-smoker ratio is not high in India compared to Western countries. Why it is so? In Western countries, the males are, COPD is more common among males because males are smoking more, and they are going out more in the industries, factories, and all. They are more prevalent in males, and females compared to the females. And smokers and non-smokers, the prevalence is more among smokers in other countries or in developed countries. But in India, due to the usage of why in India, the non-smokers are also getting the COPD because of the biofuel usage. You just see the picture. Because of the usage of wood, dry cow dung, etc. For in the cooking purpose, the females are getting this disease equally that of male in India. Most polluted cities in the world are in India. So that is the statistics. According to 2019 air quality report, 21 of the world's 30 cities with the worst air pollution are in India. That means around 21 out of 30 cities which are most polluted in the world are from India. That is very alarming. And we, out of this, Ghaziabad, which is the city, the NCR city, which is in the state of Uttar Pradesh, is ranked as the world's most polluted city with an average of PM means particulate matter 2.5 concentration measurement of 110.2 in 2019, which is 9 times more than the normal value. That is, this way you just see the flow chart of a chart. The normal value, which is preferable, is the particular matter normal value is in between 0 to 12. But in the Ghaziabad city, it is around 110. That means around 9 times more than the preferred range of particulate matter. That is so much alarming and hazardous for the health of the persons who are living in those cities. And the other polluted cities are the Delhi, which is ranked 5. I am also staying in this city only. Noida, which is near to Delhi, and Gurugram, Greater Noida, Bandwari, Lucknow, which is ranked 11, Bulandshahr, which is ranked 13, Muzaffarnagar is ranked 14, Baghpat 15, Jind 17th rank, Faridabad 18th rank, Korot 19th rank, and Bhiwadi 20th rank. So almost all these major cities, main cities which are more polluted are coming in the states Delhi, Uttar Pradesh, Rajasthan, and Haryana. The air quality index of many Indian cities are very poor. Why it is poor? Very poor. So air quality index of Delhi NCR cities are generally moderate to unhealthy. That is 51 to 200. That means up to 50, it is good for living. Actually, the ideal condition is 0 to 50 air quality index. If it is between 51 to 200, it is considered as unhealthy. So in Delhi and NCR cities, usually it is between 51 and 200. And then it's during the winter season, it will go. So then it is drastically deteriorates to very unhealthy and hazardous. Hazardous level means 300 to 500 level. Between the months October to December. Why it happens? So during the month of October to December, it is the winter season, and there is less movement of the air in the atmosphere, and that also contributes for the increased level of of this air pollution. This is due to the various factors, including stubble burning. You can see the picture, the stubble burning. Usually it happens in the northern India, in the villages. And due to this stubble burning, there will be increased pollution. And vehicular pollution, that is one of the cause, rampant constructions in the cities, road dust, firecrackers burning during Diwali and the other festivals, and the cold weather that I already explained. During the winter, the cold weather triggers the air quality deterioration. Then just go through the air quality index. I told you that 0 to 50 is the ideal condition. The air pollution poses little or no risk. In between 51 to 100, it is moderate air quality. Health concern for people who are unusually sensitive to air pollution. Few individuals will get some diseases. From 101 to 150, unhealthy for sensitive groups. Sensitive groups means the young children and elderly people. Then 151 to 200 is everyone may experience health effects. Sensitive groups may experience more serious health effects, usually during the winter season. Then very unhealthy, if the air quality index is between 200 and 300, so it is an health alert, and everyone may experience more serious health effects during this, if the air quality index is between 200 and 300. Then the hazardous condition, so health warnings of emergency conditions, if it is between 300 and 500, it is a very serious condition. Sometimes in northern India, many cities reaches air quality index up to 400. Then we come to the COPD proper. So already we discussed what are the causes, what are the triggering factors, which are risk factors, which causes the COPD. And in India, there are so many risks, or cigarette smoking is there, and other risks already I explained. And what are the symptoms we can get? Common symptoms of COPD, is my main symptoms which we get is breathlessness. That means there is an hair hunger. The excessive sputum production, that means continuous sputum production, and chronic cough. There will be persistent cough will be there, and wheezing is there. So continuous wheezing will be there. Chest tightness. These are the main symptoms. This my patient will present when coming to your clinic or coming to the dispensary. Then in chronic COPD patients, if the COPD complaint, chronic obstruction is there for last 5 to 6 years, there will be some systemic features that you must understand. If the patient with chronic COPD comes, we can expect, that is important, we can expect certain other features also in patients with COPD. What are they? So my first one is skeletal muscle wasting. He'll be having some muscle wasting, cachexia, loss of fat, free mass, depression. Why depression? Depression because of the continuous suffering. So many patients will go to the depression. And lung cancer, one of the risk factor for the lung cancer is COPD itself. Then one of the complications of COPD is the pulmonary hypertension that will develop to the pulmonary hypertension. Then ischemic heart disease. What happens is the COPD will lead to the right ventricular hypertrophy, and that can gradually affect the heart problems and can lead to the ischemic heart disease. Then one of the other systemic manifestation is osteoporosis among the aged. Normocytic anemia will be there, and the diabetes mellitus and metabolic syndrome. If due to the constant use of the bronchodilators and also the steroids, that can lead to the metabolic syndrome or diabetes mellitus. And these things are there. These are the systemic features of COPD. Then what is exactly the COPD? What are the components of COPD? Usually everyone knows chronic bronchitis. There is a part of chronic bronchitis and it's emphysema. So chronic bronchitis is cough and sputum for most days for at least 3 months in each of 2 consecutive years. And in emphysema, the condition is different. Abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls without obvious fibrosis. So there is no fibrosis, but the air spaces, that means alveoli are damaged and it lead to the the hyperinflation of the lungs, and that is the condition in emphysema. So that means it is a combination. Sometimes it is a combination. Sometimes there will be a predominance of emphysema. That is a COPD with predominant emphysema features. And in certain individuals, we will get COPD with predominant chronic bronchitis features. Then what is the pathology? This is chronic bronchitis and emphysema. This the pathology is different in both conditions. In chronic bronchitis, the pathology usually what happens is the mucus glands will increase, and there will be hypersecretion of the mucus and hypersecretion of the sputum, and that will clog the bronchial tubes, and that will trap the air and limit the airways. That is the main pathology which happens in the chronic bronchitis. This, as may just see the picture, this is the healthy airway, and this may, when the mucus and sputum are there, these airways will become blocked, obstructed. That will lead to the COPD. And the second one is the emphysema. The picture, my healthy alveoli is like this with distinct walls. But what happens is in emphysema, the alveolar walls will become the binding material of the alveolar, the elastin will loosens and the will damage, and the alveolar wall will become distorted, and that will lead to the emphysema. That is the pathophysiology of emphysema and chronic bronchitis in COPD. So what is read index? That you should know. It is a physiology part anyway. So my read index is the ratio of mucus gland layer to the thickness of the wall between the basement membrane and the cartilage. Just see the picture. This is the the cartilage, and this is the basement membrane. So usually what happens, this is the mucus glands which is present in between this the wall, in the wall of the bronchial tubes. Actually, read index is mucus gland divided by wall thickness. Normal range should be 0.1. That means mucus gland 4 out of 10 should be there of the mucus glands. But what happens is what happens in bronchitis, the mucus glands will become hyperplasia of mucus glands happens, and they will secrete more. They will multiply, and that will increase the number of mucus glands and the layer thickness. So then the read index will become more than 0.4, and if it is more than 0.5, it is a condition. The condition is called chronic bronchitis. Then this is again we are explaining that is my normal bronchial wall and chronic bronchitis bronchial wall read index difference. This is the difference. I already explained it. This is the normal one, and this is the bronchial wall of the chronic bronchitis. In the first picture, these glands are less, and in the second picture, there is hyperplasia of glands and this increased mucosa glands, and the distance, the thickness of the glandular layer will increase, and the read index is increased. Then comes the pictorial representation of COPD patients, because I already explained that is a part COPD with predominant bronchitis and COPD with predominant emphysema. So if the bronchitis, chronic bronchitis is predominant, it is called blue blotter. Then the patient, you just see the picture, he is an obese person actually. So with the symptoms, chronic productive cough. There will be chronic productive cough because bronchitis is predominant. Purulent sputum will be there. Hemoptysis may or may not be there. Mild dyspnea initially, but gradually the dyspnea will increase. So that cyanosis is most important part. That is why they are called blue blotter, because it is because of the hypoxemia. So hypoxemia is more predominant in chronic bronchitis because the patient is lacking the oxygen, and that is why his lips are blue, tinged with blue, and as my extremities have fingers become bluish, and that is why they are called blue blotters. Then there will be peripheral edema due to cor pulmonale. In the later stage of chronic bronchitis or COPD, there will be cor pulmonale. Crackles and wheezes are the predominant auscultatory findings. There will be prolonged expiration, and the patients are obese. Obese, that is one important feature. The obese persons with these symptoms. Complications are secondary polycythemia vera due to hypoxemia. Why there is polycythemia? Because there is hypoxemia, then that will increase the number of RBC, because there will be erythropoietin secretion in the kidneys, and that will lead to the polycythemia. It is a secondary polycythemia. That is one of the important feature of chronic bronchitis. Pulmonary hypertension due to reactive vasoconstriction from hypoxemia. So pulmonary hypertension is one of the complication of the chronic bronchitis because of the hypoxemia. And core pulmonary is from chronic pulmonary hypertension. Then the stages are chronic bronchitis, then that will lead to pulmonary hypertension, then that will lead to the right ventricular hypertrophy or core pulmonary. Then pictorial representation of the COPD patient, that is emphysema test patient. If the emphysema is predominant, they are called pink puffers. Pink puffers, just see the picture. They are usually not obese. They are thin, lean, with indrawing respiratory muscles. Symptoms are dyspnea. There is not that much cough as that of bronchitis. Minimal cough. Increased minute ventilation. Hyperventilation is there. Because of this hyperventilation, they are called pink puffers. They are having pink skin, pursed lip breathing. Accessory muscles are used. You can just see the picture. There is accessory muscles are used. Cachexia is there. Hyperinflation is there. Barrel chest is the main important feature because of the emphysema. Decreased breath sounds and tachypnea. These are the symptoms, and the complication is pneumothorax due to bullae. So emphysema will lead to the bullae, and that can lead to the pneumothorax. When the bullae ruptures, it will lead to the pneumothorax. Weight loss usually happens in the emphysema predominant COPD patients because the patient is constantly working hard for breathing. Then how we can diagnose COPD? There are few important points to remember while diagnosing the COPD. Key indicators for considering a diagnosis of COPD are chronic cough. Chronic, so first feature is chronic cough present intermittently or every day. Every day there will be cough, or it can be intermittent also. Often present throughout the day. So that is very important. Cough is present throughout the day. So in asthma and all, cough usually increases during night, but that feature is not there in the COPD. Seldom only nocturnal, that I already told you. The it is not nocturnal. It is, the cough is there throughout the day. Chronic sputum production. Any pattern of chronic sputum production may indicate COPD. Why it is so? Because any type of sputum. That means it can be whitish, it can be creamy, it can be yellowish, or any type, because sometimes there will be added respiratory infections along with the COPD, and that can cause the yellowish or greenish sputums also. So dyspnea, usually there is a breathlessness or dyspnea that is progressive. That usually initially it is less and gradually it increases. Persistent, present every day there is dyspnea. Worse on exercise, usually cannot tolerate exercise much. Worse during respiratory infection. That means if there is an influenza, that's pneumonia, COPD cases, increases their sufferings. History of exposure to risk factors. Already we discussed these things. If there is an history of tobacco smoke, occupational dust and chemicals, or smoke from cooking, or household usage of biomass fuels. Then this chart, this one is important. You have to remember the dyspnea scale. This dyspnea scale is followed throughout the world. This is called the Modified Medical Research Council Dyspnea Scale. This is used for the assessing the dyspnea levels of the COPD. So you have to understand what is the scale. So there are 5 grades, 0 to 4. You just see the pictures which is given in the top of this chart. The first zero grade means they are normal persons, not troubled by breathlessness except on strenuous exercise. That is normal individuals. If they are playing, if they are running and all, they will develop some dyspnea. That is normal. That is grade third under grade 0. And the grade 1, shortness of breath when hurrying on the level or walking up a slight hill. He cannot. There will be shortness of breath while going upwards or climbing steps and all. That is the first stage of dyspnea. Then second grade is walks lower than people of the same age on the level because of breathlessness or has to stop for breath when walking at one pace on the level. That means if 2-3 persons are walking and one person is not coping with this, he is not walking that much fast as of the others. And he is breathless. That is considered as the grade 2. Stops for breath after walking about 100 meters or after a few minutes or on the level. So if a person cannot walk more than 100 meters in a continuous stretch, that type of dyspnea comes under the grade 3. And the grade 4 is too breathless to leave the house. He is reluctant to go out of the house or for household works and all. Then that is considered, he is very much dyspneic, always breathless. That is considered under the top category, grade 4. So you just see the pictures and this that they can understand it in a better manner. Then diagnosis of COPD, what are the physical signs which they depend on the degree of airflow limitation and hyperinflation. That means the physical sign can be the bronchitis, physical signs will be different, and the emphysema, it can be different. Tachypnea, pursed lip breathing, weight loss, barrel-shaped chest, polyphonic wheezes, and crackles. These are the physical signs we can get when a patient or comes to your clinic or the dispensary and all. Presence of pitting edema in advanced disease. If it's COPD chronic cases, we can expect the pitting edema due to hypoxic hypercapnic kidney, failure of salt and water excretion by kidneys. Then features of pulmonary hypertension and right heart failure. In the later stages, we can find these features of pulmonary hypertension and also the right heart failure. Then, according to the GOLD, which I told you, the organization GOLD, this made that how we can conclude the diagnosis of a COPD, pathways. So, if there are the symptoms, these symptoms, shortness of breath, chronic cough and sputum, already I explained, and these are the risk factors, host factors. Tobacco means antitrypsin antibodies, alpha-1 antitrypsin antibody, host factor of the tobacco smoking, occupation, indoor or outdoor pollution. Then along with that, if it's my way to go for a spirometry test and this may establish the diagnosis. Then what are the investigations? Most maybe knowing what still I will explain those investigations which are important. Chest X-ray means in X-ray we will get if there is a emphysema predominant, the features of emphysema will be there, and chronic bronchitis predominant, the bronchitis symptoms will be there. Those blood tests to exclude, there will be anemia and polycythemia. I already told you why there is polycythemia. Then third is alpha-1 antitrypsin in the young patients with basal emphysema. So it is produced in liver, and we have to test the alpha-1 antitrypsin. If there is any deficiency, we can find it out from the investigation. Spirometry is the main investigation. Then last one is peak flow measurements. So it is used by, measured by the peak flow meter. I will explain in later slides. Then other investigations are HRCT, high resolution computer tomography can detect the emphysema and its complications. It is high resolution tomography CT. Then for emphysema it is used to find out the bullae and all. So CECT is contrast enhanced computer tomography of chest, is used to evaluate dilated pulmonary artery. It is usually useful if there's to check whether there is any pulmonary hypertension. So sputum examination to rule out bacterial infections during acute exacerbation. So if there is any infections. So ABG, arterial blood gas analysis, has to be done. It is usually done when if the patient is hospitalized and the facility is there in, only in the hospital setup. The pulse oximetry, instead of ABG, we can use pulse oximeter. It is a more convenient to test, but the specificity or the confirmatory diagnostic, it is not that much diagnostic, but the progress of the disease can be assessed with the pulse oximetry. These are the chest radiographs of COPD. In chronic bronchitis, what you can expect, these vascular markings will be prominent vascular markings in initial chronic bronchitis COPD. In the later stages, the bronchial thickenings also can be there, scarring also we can see in the lung X-ray. Then in emphysema, you will find out the hyperinflated lungs with a reduced vascular markings. Vascular markings will be less. The lung is hyperinflated. There is barrel shape and then the dome or diaphragm is more. It is more straightened actually. Then main investigation or diagnostic one of the diagnostic investigation of this is spirometry for COPD. So this is the picture how patient is assessing this lung function through spirometry. So there are three measurements for the spirometry. So you may be knowing. Well, first one is FVC, the other second one FEV1, and the ratio of FEV1 and FVC divided by FVC. FVC or for forced vital capacity, which is the greatest total amount of air one can forcefully breathe out after breathing in as deeply as possible. If the forced vital capacity is lower than normal, something is threatening. That means if the forced vital capacity is lower than, there is a normal predicted value. But if it is less than that, this means there is some restriction or obstruction in the breathing. So normally it should be 80% or greater of the standard value. FEV1 is, this is the amount of air one can force out of your lungs in 1 second. In 1 second, how much air we can force out after full inhalation? A lower than normal FEV1, that means forced expiratory volume in 1 second reading, shows a significant breathing obstruction. That is very important parameter. Percentage of predicted FEV1 value is usually 80% or greater. It should be 80% or greater in normal individuals. So those persons who are having obstruction, it should be below 80%. The ratio of FEV1 divided by FVC, that means a forced expiratory volume in 1 second divided by forced vital capacity, is between 70% and 80%. Usual normal value is 70 to 80. But if it is less than 70%, there is air that means that there is airflow limitation, and it is pointing towards COPD. FEV1 is influenced by the age, sex, height, and ethnicity, and the best considered as a percentage of the predicted normal value. Then according to GOLD, the classification or airflow limitation severity in COPD. What is the classification usually? You may be knowing GOLD, this is the main important classification of chronic obstructive pulmonary disease. So first one is FEV1. The first consideration is it should be below 70%. That means forced expiratory volume in 1 second divided by forced vital capacity should be less than 70%. Then in the first category, if the FEV1 predicted is between 80% or more than that, it is considered as a mild category. If the FEV1 is between 50 and 80, it is considered in the moderate category, that is GOLD 2. And the GOLD 3, the severity is severe, and FEV1 is between 30 and 50. And the GOLD 4, the classification, it is very severe, and the forced expiratory volume in 1 second is less than 30% of the normal value. So you have to understand these values. So that will be because patient will be coming to you with these spirometry reports, and you should know the severity of the disease according to these parameters. Then GOLD stages based on severity. There are a few more explanations for that. Stage 1, I already told you, it is very mild with FEV1 about 80% or more of normal. Commonly in this stage, COPD causes light airflow limitation. Usually very mild cases. There is not much problems are there, and as a mild airflow limitation, patient is not having that much complaints. The second stage, usually the patient comes to the clinic or your OPD when it reaches COPD stage, reaches to the level moderate. FEV1 between 50 to 80% of normal. Usually during this stage, most people seek 80% is 0.8. Sorry. Usually during this stage, most people seek help for COPD symptoms of coughing, wheezing, and shortness of breath. So, and they will come for the consultation. So patient will come when there is a moderate symptoms and the FEV1 between 50 to 80. Then in the severe cases, emphysema with FEV1 between 30 and 50% of normal. Typically in this stage, COPD symptoms worsen, causing decreased quality of life. Patient will be experiencing more problems and quality of life will become decreased in this stage of stage 3, and patient will be reaching to the hospital many times because of the recurrent ailments. And if the severity is more, if it is become very severe, that means GOLD stage 4. With a lower FEV1 than stage 3, or those with stage 3 FEV1 and low blood oxygen levels, generally this stage is known as end stage of COPD. That means it is end stage, meaning the disease has progressed, lung function has deteriorated, and flare-ups could be life-threatening, because in this stage, patient needs hospitalization, he may be he may need some ventilatory support, and it is the end stage of COPD. Then I'll explain some points about the peak flow meter. The peak flow meter will be useful for the COPD diagnosis, but usually it is more useful in asthma patients. What is peak expiratory flow rate? Is measured by using the right peak flow meter, by blowing to a small instrument. It is a very cheaper instrument. It can be used in the at your home. So it is more handy. So it can be used for the screening of COPD patients rather than diagnosing these COPD patients. Normal value is more than 400 liters per minute. That means 400 to 500 is the normal value in normal individuals. If there is an airflow obstruction, what will happen? It will be lower than 200 liters per minute. A low peak flow is consistent with COPD, but is non-specific, does not discriminate between obstructive and restrictive disorders. So low peak flow is seen in COPD also, but it is not that much diagnostic, because this means asthma also it can come down in other restrictive disorders also. So this can come down. Little or no diurnal variation is observed in COPD in contrast to bronchial asthma. In bronchial asthma, why this peak flow meter is useful? Because of the diurnal variation of the readings. This means in bronchial asthma, there will be increase of the symptoms, or increase of the sufferings in the night, and there will be a diurnal variation of the peak flow reading. Then the blood gas analysis. In blood gas analysis, you must know what are the parameters, or we should have an understanding. Arterial oxygen saturation. What is the normal saturation level of oxygen is in blood gas analysis 95 to 98, and the partial pressure of arterial oxygen is 80 to 100 millimeter of Hg, and partial pressure of carbon dioxide is 35 to 45 millimeter of Hg. In COPD, what happens is This PS, partial pressure of carbon dioxide increases and partial pressure of oxygen decreases. That means that will lead to respiratory acidosis. So these values are important. If the patient get admitted in the hospital, they will be analyzing blood gas and these parameters. According to the parameters, they will, in the hospital setup, auxiliary measures will be advised. Usually the indication, if the patient is in a gold 4 category and there is he needs the ventilatory assistance, the parameters are partial pressure of carbon dioxide should be above 44 and partial pressure of oxygen below 50 millimeter Hg, and FEV1 or peak respiratory flow rate are less than 10% of the predicted value. That means FEV1 should be around 60%, 70, above 70 is normal, I told you. Then that is it should be 10% below. And a peak respiratory flow rate, that means 200 should be the normal level, and it should be below 200 or 10% below the 200. Then it is an indication for the ventilatory assistance. Then BODE index, this is one criteria tool that is used to predict the mortality rate from COPD. How many patients, severe COPD patient, how many years of survival will be there for that COPD patient can be assessed with the BODE index. That is you should know what are the parameters considered in the BODE index. So my first one is body mass index. Body mass index means the criteria of the body weight, obesity level and all. So degree of airflow obstruction by using the FEV1, what is the predicted value of the FEV1, and measurement of the dyspnea. Already I explained the dyspnea scale and the 5 grades of dyspnea scale. So that is the third criteria for the BODE index. And the fourth one is exercise capacity. Exercise capacity is the distance walked in 6 minutes. That means how much distance he can cover in 6 minutes. That is how much meter. So if it is the points, the point system is given, you just go through the point system 0 to 3. This if these parameters, if the patient's parameters worsens because degree of airflow obstruction is more or measurement of dyspnea is more, then the patient will be getting more points. That means more points. Point means is the survival rate is less. So you just calculate the points. Thus, my approximate 4-year survival interpretation is 0 to 2 points. 0 to 2 points. There is an 80% survival. That is, if the patient is having only BODE index only 2, that means he will be surviving more than 4 years. That is 80% chance is there. So if it is 3 to 4, the 67% of chance is there. He will be surviving after 4 years. Then 5 to 6 points, the 57%, and 7 to 10 points, 18. That's why the chance of survival after 4 years is 18%. So this BODE index is important for the prognosis of the disease. Then there is a COPD assessment test. This can be used in your clinics or in the hospitals or for the research purpose also, for the assessing the COPD patients and their progress of improvement. So it is a very good measure before and after. We can assess after the treatment, before treatment and after treatment, and also the severity of the patients in the different categories. So what are there are 8 questions in that. So first one is I never cough. There are 8 questions and scoring is 0 to 5. So I never cough or I cough all the time. I never cough will get 0 mark, and I cough all the time will get a 5 mark point in the scoring sheet. Then second question is I have no phlegm in my chest at all. That is a 0 mark, and my chest is completely filled with phlegm. It's my 5 mark. If the patient is having in-between symptoms, and he can mark 2 or 3 or 4 according to his severity. My chest does not feel tight at all, 0 mark, and my chest feel very tight, 5 mark. Or when I walk up to hill or one flight or stairs, I am not breathless, it's a 0 mark, and it's my 5 mark when I walked up a hill or one flight of stairs, I am very breathless, that will be 5 marks. I am not limited doing any activities at home. 0 to 5 marks are there. I am very limited doing activities at home. That's the score of 5. I am confident leaving my home despite my condition. I am not at all confident leaving my home because of my lung condition. So you have to score in between 0 and 5. I sleep soundly. I don't sleep soundly because of my lung condition. So my scoring should be in between 0 and 5. I have lots of energy. I have no energy at all. That also is to be written. So according to the patient's severity. So the total, there are 5, the scoring can be in between 0 and 40 because there are 8 questions and 5 up to 5 marks, and this may go 0 to 40 is the scoring rate. The CAT score analysis, how you can analyze the CAT score, the range of CAT score is 0 to 40. There are 8 questions and 5 marks. Higher scores denote a more severe impact on COPD on a patient's life. That is important. That's why if a patient come to their dispensary with a score of 30 initially, and this may after treatment, after 12, 15 days, after 30 days, if you assess if you give the scoring as scoring again, so if he improves to and the score is only 20, that way we can analyze the improvement of the patient. So again, this CAT score can be used for the research purpose and for the studies of this COPD. The difference between stable and exacerbation patient is 5 units. That means if there is an acute exacerbation, so a patient can the scoring rate can increase up to 5 units. Then what are the difference between a COPD and asthma? So it is because asthma and COPD both are having common symptoms also. So it is important to differentiate between the COPD and asthma. The onset, usually I told you COPD onset is in the middle age and asthma usually in the early life, from the childhood usually. Symptoms slowly progressive. In asthma, it is diurnal and seasonal variation. Asthma, there will be a seasonal aggravation and can be in the night. Diurnal variation usually aggravate in the night. History, long smoking history. COPD, more common smoking history is there, exposure to smoking or biomass fuel or air pollutions, and all are there in COPD. And in asthma, usually due to the history of allergies, rhinitis, and eczema, etc. But even the allergy or eczema and all allergies can trigger the COPD also. Inflammatory cells, neutrophils. Usually the inflammatory cells are neutrophils in COPD, and the asthma eosinophils are increased. And the airway hyper responsiveness is more common in asthma than COPD. Airflow limitation largely irreversible. COPD is largely irreversible. Only less than 15% of the change can be made in COPD when the patient improves. So in asthma, it is very much reversible. More than 15% or 200 ml change is possible, is there when there is a recovery from the asthma, or in between when there is not much severity, the patient the symptoms are reversible. Then there is one more condition, because we are discussing about COPD, but sometimes we will get a overlap syndrome. So nowadays it is called as ACOS. That means asthma COPD overlap syndrome. So there will be asthma symptoms also and COPD symptoms. So in individuals with both the symptoms of asthma and COPD, this condition is called ACOS. Asthma COPD overlap syndrome is characterized by persistent airflow limitation with several features usually associated with asthma and several features usually associated with COPD. Because asthma symptoms are also there, then COPD symptoms are around 15% of the patients who are coming, whom we are diagnosing as COPD or we are diagnosing as asthma comes under ACOS category. So differentiating the asthma patient, COPD patient, and ACOS patient is important. So ACOS is therefore identified by the features that it shares with both asthma and COPD. Then what are the goals of COPD management? How we can manage a case when it comes to this? So what are the goals? So it's relief, you give the relief to the symptom, so the relief of the symptom, prevent disease progression. So we have to progression has to be stopped, improve exercise tolerance, improve health status, prevent and treat complications. By giving medicines, you have to reduce the complications, prevent and treat exacerbations. That's reduce, because the frequent attacks of the exacerbations has to be reduced. If your medicine is working well, so that has to be controlled, and my complication has to be controlled, and the mortality rate has to be reduced, and the morbidity or mortality has to be reduced. Then what is the difference between general management and homeopathic management? How we can approach, or how we can manage the COPD case? What are the general management? That is very important. That is the part we neglect usually. But general management is equally or more important than our medicine management in the case of COPD, because there are so many triggering factors. There are so many things of consideration. So general management, you have to understand what are the general managements, and you have to advise the patient, or you have to give him the practice of the general management. So what first one is the cease to smoke. This is the most important and highly mandatory step in treatment plan of COPD. We have to give the enough assurance or enough confidence or enough support to the patient to quit smoking. That is the first thing you have to do. And the second one is this: if the patient is gold 3 or gold 4 category, this is oxygen therapy. In order to enhance the oxygen levels in the blood, supplemental oxygen can be given through a portable mask to help the person breathe better. It increases the survival rates in the patient and improve the quality of life. So oxygen management. So in the homeopathic colleges, we have to use this oxygen therapy along with other medicines in COPD, or those persons who are admitted in the hospital setup. So we have to give oxygen therapy. Even in home conditions also, oxygen kits are available. So by giving medicines along with that, we can advise the oxygen in oxygen therapy. Pulmonary rehabilitation. This induces a mix of exercise, education, and psychological support to help patients with debilitating symptoms. So pulmonary rehab, there is a separate wing of pulmonary physiotherapists in major hospitals, because they will advise the exercise. So different type of exercises, aerobic exercise, walking exercise, stretching exercise. All these are as useful in COPD. And also the yoga, pranayam, meditation. Meditation is helpful in this patients with depression. And the yoga and pranayam yoga, pranayam, breathing exercise can improve the lung capacity. And so we have to give the advice for the patient regarding the exercises. And then comes the homeopathic management. Give considerable importance to the following aspects while taking the case. You should be very proper in taking the case. History of presenting complaint, how long it is there, when it started, what are the post-causes. The causation is important. Whether there is any history of addiction, smoking, or any other substance intake, or any other exposure to the industries, or working in his occupation, and all these things are comes under the causation. Past history, any past history of smoking, and family history of COPD, or family history of any other diseases. Treatment history, what are the medicine, bronchodilators, steroid, what are the medicines he is taking. This is my miasmatic background. Usually there is no miasmatic background if it is there. So I will explain regarding this in the later slides. Peculiar cure or rare symptoms of the case. That is the important. That is very important for the final prescription of the medicine. Then this is the pulmonary rehabilitation through spirometer. This is you just see the picture. This is the spirometer. Spirometer can be used for the lung exercise. This is a small instrument, which can be used in the home of the patients also. So maybe they can explain it. I will show you this instrument is with me actually. I will show you the instrument. Can you see this? This is the instrument. We have to take the breath, deeply inhale the breath. These balls will come up, and a patient has to take a deep inhalation. So around 4 or 5 times, gradually increasing the number. And if he practice this spirometer exercise, the lung capacity will increase, and that will reduce the frequent attacks of the COPD. So this is the instrument that you can, it is very, it is not that much costly also, that can be purchased in the Amazon and from anywhere. So, and I can advise the patient for using this instrument, which is spirometer, for the lung exercise. Then what is the homeopathic perspective? COPD, a non-miasmatic chronic disease. So what it is actually? This may according to Hahnemann, there are 2 groups of diseases. One is the miasmatic diseases. One is the other group he has considered is non-miasmatic chronic diseases. In non-miasmatic chronic disease, there is some. They again classified into pseudochronic disease, inappropriately called the chronic disease, drug diseases, and occupational diseases. Occupational disease usually that means that the non-miasmatic there is no miasmatic background, but it's my occupation disease or drug disease is due to the allopathy drugs, also my continuous use of the drugs, or pseudochronic diseases. It can be come under the pseudochronic disease or occupational diseases, non-miasmatic disease category, because of one of the main risk factors are the cigarette smoking, pollution, and the industrial pollution. And such environments are the triggering factors for the COPD. If the patient can be removed from these causes, the COPD patient will improve. So this can be considered as in the category non-miasmatic chronic disease. This is the charts. Everyone knows the chronic disease, non-miasmatic and miasmatic, and the miasmatic comes with the psoriasis, severe psychosis, and the compound diseases, and non-miasmatic pseudochronic, drug disease, and occupational diseases. Then management of pseudochronic disease. In the aphorism 77, Hahnemann has explained about the pseudochronic diseases from bad hygienic condition of living. So that is appropriate for the COPD cases, because when some person is living in North India or in a highly polluted city, so the hygienic conditions, it's not, weather is bad, and it is a constantly avoidable noxious agent. If it changes this place from that area to a better non-polluted area, it can be the condition can remove the disease. Ailments from agents which undermine the health, unhealthy localities, abstinence from things necessary for support of life, overexertion of mind and body, lack of exercise, injurious liquor. These are the avoidable noxious agents, which is mentioned by the Hahnemann under pseudochronic diseases. What is the concept? So diseases as a result of these influences would disappear on improved mode of living if no chronic miasm present latent hidden in the body. So if you remove these causes, or it is maintaining causes, with the disease will be can disappear. So if there is any underlying chronic miasm, that's why we can treat after removing this noxious agents. This way we can, if there is any underlying miasm, this way we have to treat that miasm. The disease is treated after removing the maintaining cause. So that should be your the management part according to the Hahnemannian view. Then the treatment barriers. These are the treatment barriers already explained. Maintaining causes of COPD. One is tobacco smoking, indoor air pollution that can be removed, outdoor air pollution that can be removed, occupational dust and chemicals. Without removing these causes, the success of homeopathic treatment will be minimal. So while giving the advice or while giving the treatment, we have to consider this part, consider the Hahnemannian advice of the pseudochronic disease. So of removing these causes first before treating the patient of COPD. So what are the limitations? Then what are the limitations we are facing in homeopathy? The first one is COPD cases are of the nature of pseudochronic disease or occupational disease. I already explained it. Difficult doing the maintaining cause. That is example, smoking sachets. Even though it is easy to say that you have to quit the smoking, but it is in patients, it is very difficult. Many persons, they again start smoking, or even though the condition is very severe, they are not able to quit the smoke. So we have to give that much support to the patient for quitting the smoking. Curtailing the pollution, so that is also important, because of the other circumstances, if a person cannot leave a polluted city because he is working in that city and he cannot move out, or children are studying there, so he cannot move out. So then it will be difficult to remove that cause. Industrial exposure, if he is working in an industry or factory, it will be very difficult to leave the job actually. Or then he will be constantly exposed to the particulates or this pollution and all. Or then removing the maintaining cause is not that much easy. Then irreversible and incurable nature of the disease, because it is an irreversible disease and incurable nature, and because of the maintaining cause, and there are so many limitations while treating a COPD case. Then action of the remedy in COPD cases as per the observation. As per the kind of observation, 3 observations I taken out. So the first one is a prolonged aggravation and a finite decline of the patient. This is applicable because in the GOLD stage 3 and 4, prolonged aggravation and a violent decline of the patient, incurable. Vital reaction impossible. Never use high potencies, low potency medicines are advisable. According to Jetikens, a prolonged aggravation and finite decline of the patient, this may we have to use the low potency medicines. So vital reaction is impossible in such conditions. Usually in COPD cases in the stage 4. Long aggravation but final and slow improvement. The borderline, these are the borderline cases. Beginning of tissue changes, prolonged treatment needed for the recovery. We can consider the GOLD stage 1, stage 2 and stage 3 in this category. Full-time amelioration of the symptoms, yet no special relief of the patient. The patient with the structural changes in certain places, patient is palliated in this instance with homeopathic remedies. In this condition, so we can give only the palliation. We can give the maintaining cause is still there and the full-time amelioration is there, but we cannot remove the maintaining cause. So then the patient will be getting only a palliation from our medicines, and the low potencies can be used. Then what are the scope? What is the scope of homeopathy? In mild COPD case, that is GOLD 1 category, remove the maintaining cause and treat symptomatically. That is the first thing. Remove the cause and this may treat symptomatically. Anti-miasmatic medicines are to be given if there is underlying miasmatic features. After removing the maintaining cause, if the miasmatic features or if the miasmatic fundamental miasm picture is remaining, then this we have to treat the miasmatic features also. In moderate COPD cases, remove the maintaining cause, treat symptomatically, use low potency medicine. Prolonged treatment is needed for recovery. In GOLD 2, we need a prolonged treatment, but still it can be reversed to a certain extent in the persons who are in the GOLD 2 category. In severe COPD cases, GOLD 3, incurable stage, not reversible, only palliation is possible. Low potencies are to be used for palliation. Pulmonary rehabilitation. In this case, so we have to advise the pulmonary rehabilitation exercises and general management, and we have to give more importance to the general management part also. are to be followed. Hospital care is necessary to tackle the exacerbations. If there is an exacerbation, the patient has to be hospitalized. In very severe COPD cases, goal for immediate hospital care is needed. Palliative medicines in a very low potency is advisable along with necessary general management. So it is the end stage, but still palliative medicines can be tried, and this patient will get some relief, and can extend the lifespan of the patient with some of our medicines. Then what are the certain tips to improve our clinical success in COPD cases mainly? So what are the important points we have to remember while to improve our clinical success? Give due importance to the examination of the patient, example, inspection, auscultation, etc. The problem we are facing in many of the homeopaths are facing, we will take the case, entire case, all the mental symptoms, physical symptoms, but we will not touch the patient, we will not auscultate, we will not inspect, and we will, that part we lacks actually. So even though we studied everything, we are reluctant to use the stethoscope and we're reluctant to write the investigation. Those things should not happen. So maybe we have to inspection, auscultation, that will give you more points, because it's whether there is any bronchitis, whether there is any emphysema symptoms, or so then medicine, the picture of then medicine also changes. Pathological symptoms also changes, so the prescription can be changed because of the after the examination of the patient. Conducting proper investigation of patients to rule out similar complaints. So that is important, because instead of going for this blind diagnosis, you send him for the investigations, blood investigations, spirometry, and all other investigations, is to rule out the other DDs. Proper usage of auxiliary measures in the general management of, already I explained what are the general management we can use, the oxygen therapy, the pulmonary rehabilitation, and also the yoga, breathing exercise. All these things we have to advise the patient. Giving proper advice regarding diet and regimen, lifestyle what are the lifestyle modifications has to be done with a healthy diet, and quitting the smoking, and living away from the polluted atmosphere. These are the lifestyle modification needed. So that is important for your clinical success. Adequate understanding about the scope and limitation of homeopathy treatment in different stages. That is important. What are the stages? For 4 stages are there. In stage 3 and stage 4, patient needs a hospital care. Actually, in that time, the exact time of referral, you should have an idea about when you have to refer the patient to the hospital, when you have to when the patient needs an ventilation support. All these things you should know. So adequate understanding and scope, and what are the limitations, in which stage homeopathy is having a scope, and in which stage we are having limitations. So according to the stages of COPD. Then comes the acquiring proper knowledge of medicines, potency, dosage, and repetition. Dosage, potency, repetition, these things you should have a thorough knowledge in the condition of COPD, because usually the potency selection, rather than the very high potencies, the low potencies and the are more effective in COPD cases. Giving importance to a detailed case taking presenting complaint as history of person. Already I explained this. Judicial usage of repertories and mastering of the rubrics available in this, because after using the repertories will enhance your knowledge, and that will improve the prescription style, and this may improve the knowledge of the medicines. Developing the skill to differentiate between common symptoms of the disease and peculiar symptoms of each individual case. That is very important. And last one is practical. Be practical in prescribing homeopathic medicine. You should be logical. You should have the common sense in during the prescriptions, rather than I always say, rather than classical. You should be more practical while prescribing the medicines. Then the repertory, what are the usage? How you can use the repertories in COPD cases? Chest inflammation, bronchial tubes. In the Kent's repertory, page number 835, bronchitis is the rubric for bronchitis is inflammation, bronchial tubes, bronchitis. There are 3 marks medicines mentioned. taken out the 3 mark and 2 mark medicines. These are the main medicines: Antintard, arsenic, baratamur, Bryonia alba, Drosera, ferrum phos, Hepa, sulfipecac, lycopodium, natrum, sulphosphorus, sanguinaria, senecio, silicious, spongia, and stanamet. So many of the medicines you know, but still baratamur is given as the 3 mark medicine. Baratamur is good in low potencies for the bronchitis, especially in the aged with very much very purulent sputum and all. And ferrum phos is also given in the first, that is one of the acute medicine actually, but still it is given for 3 mark medicine. But in the ferrum phos, symptom is the bronchitis usually in children, and which there is no cough during night. So that is an important symptom. The cough, there is no cough during night. The rubrics of importance such as inflammation, bronchial tubes, bronchitis, 2 mark medicines, alumen is there, ammonium or Asclepias tuberosa, Cannabis sativa, Carbovix, Causticum, Dulcamara, Hypocyanum, Hyoscyamus, Iodum, Calibi, Calicarp, Lobelia, Rumex, Seneca, Scilla, and Terivin. These are the important medicines for the COPD with bronchitis predominance. So, out of which Asclepias is one of the rare medicines, which is having the left-sided affections with left-sided chest pains, and usually Asclepias has amelioration from bending forward. That's the symptom of Asclepias tuberosa. And Hypocyanum is also a rare category. This Hypocyanum usually is a good medicine actually. It can be given for the bronchitis in the old age persons with much sputum. Then there's a few rubrics of cancer repertory and synthesis repertory. Chest inflammation, bronchial tubes, aged people, Hypocyanum, ammonium carb, camphor, Carbovec, Drosera, Hydrastis, Lycopodium, and Nexvomica are the medicines given for the aged people bronchitis. Chest inflammation, bronchial tubes alternate with diarrhea. Only one medicine is given. That's Seneca. Seneca is one of the very good medicine for the bronchitis of the aged. COPD usually comes in the aged person. So Seneca is one of the good medicines we have to think of. Chest inflammation, bronchial tube, children. If the COPD is there in children or bronchitis is more common, Ipecac, Calicarb, and Dulcamara are the medicines given in cancer repertory. Synthesis repertory, chest inflammation, bronchial tubes. There are 4 or 5 newly proved medicines are given: balsamum, tolutanum, eupatorium, cannabinum, marum, or mucotinum, myrtus checan. These are the medicines as given. I will explain the important points of these medicines in later time. Chest inflammation, bronchial tubes, cold from every cold. This medicine is Dulcamara and Manganum. That also is an important rubric. The peculiar rubrics in Murphy are lung bronchitis. In Murphy, the chapter's name is lungs. Lungs bronchitis chronic. In that way, it is given. Separate chapter is there with the heading lungs. 3 mark his medicine is Antintard. 2 marks, there are so many medicines: ammonium carb, arsiode, basilinum, balsamum peruvianum, cantharis, Carbovec, Dulcamara, Hepa, Hydrastis, Ipecac, Calibi, Caliiode, Pulse, Seneca, Stannum, and sulfur. In complete repertory, the rubric is given as chest inflammation, chronic bronchial tubes. There are so many medicines, 3 mark medicines, that you can go through it. Then the rubric for emphysema in cancer repertory, page number 829. The 3 mark medicines, main important medicines for emphysema are ammonium carb, anti-mass. Usually anti-mass is used for the bronchitis of the aged. Antintard is one of the medicines, no, not bronchitis, emphysema of the aged. Antintard for emphysema, Eparcels, Lacusis, Lobelia. Then 2 mark medicines are arsenic, bell, bromium, camphor, Carbovec, chloralum, Ipecac, Merck, Natramor, Phalandrinum, and phosphorus. These are the important medicines for emphysema given in the cancer repertory. Peculiar rubrics about the emphysema. In synthesis repertory, chest in emphysema, dilated heart with grindtilia is given. So grindtilia can be thought of. We already told you this way, if there is a core pulmonary stage, right ventricular hypertrophy, or if there is a cardiac involvement along with this. So this medicine can be, grindtilia can be thought of. Chest emphysema, dilated heart width. Murphy repertory lung emphysema, smoking from. Separate rubric is given. So though for the smokers, we have to think about these two medicines. If there is emphysema, ammonium carb and caladium. These are the medicines given emphysema due to smoking. Complete repertory, chest emphysema, so many medicines are there: anti-mass, anti-tart, arsenic, basilinum, balsamum peruvianum, belladonna, bromium, calcarea, carbovec, chloralum, coca, convallaria, digitalis, ephedra, grindtilia, hepar, salvipecac, lobelia, merc, natramor, philandrinum, phosphorus, silice, and veratrum. Out of which is rare medicines are also there. Chloralum is there, philandrinum is there, convallaria is there. Convallaria, if there is a cardiac problems along with that, or if there is complications of a right ventricular hypertrophy, convallaria can be thought of, because there is orthopnea and dyspnea, orthopnea, and this cardiac problems are there, symptoms are there in convallaria. This is a pictorial representation of lobe-wise lung affections of medicines. Can you just recollect the lobe affections? If in the bronchitis or COPD, if the complication comes, so that will lead to the pneumonia or lung collapse or lobar collapse and all. So these medicines are also important. In upper right lung, middle right lung, lower right lung medicines. Just think about the medicines, or left upper lung, left lower lung. What are the medicines come in the right upper lung? Just see this. So these are the medicines usually have more affinity for right upper lobe. Arsenic, album, and calcarea has got more affinity for right upper lobe. And the middle lobe, the medorinum, sanguinaria, philandrinum are there. The right lower lobe, the most effective medicines, bryonia, chelidonium, calicap, lycopodium, and mersol are there. In the left upper lobe, antimass, phosphorus, sulfur, theridion, tuberculinum, myrtus, communis are the medicines. And lastly, the left lower lobe, natrum, sulf, oxalic acid, and nicolam are the medicine. So it is a slide with the lungs, the lobar affections of the medicines. So that will be useful for prescriptions. Then some therapeutics, some glimpse of therapeutics I will explain. I will not be going through all the therapeutics, but still few important medicines I will explain. The lobelia is one of the medicines which is very useful for the acute exacerbation of COPD cases. So the salient features are a dyspnea from constriction of chest, worse any exertion. Chest pain, amelioration, rapid walking, that is a symptom. And it is usually it is given senile emphysema. So if the emphysema predominated COPD cases with acute exacerbation, lobelia can be think of in the lower potency tincture 30C up to 30C. Chest emphysema, lobelia is a 3-mark medicine. Chest inflammation, bronchial tubes, for bronchitis also, it is the 2-mark medicines given in Kent's repertory. And the next medicine is grindtilia. Grindtilia, already we explained the grindtilia. Its salient features are stopped breathing, smothering of the breathing when falling asleep, wakes with a start, and gasp for breath, because patient gets stopped breathing or smothering or sensation during night, must sit up to breathe, cannot breathe when lying down, wheezing and oppression in bronchitis patients. These are the features of grindtilia, main features. And the rubrics with representation of grindtilia are respiration difficult, sleep, falling asleep, and other medicines are grindtilia, lacus, and opium. Apart from lacus and opium, grindtilia is also there in Kent's repertory. Respiration arrested sleep on grindtilia, lacus, and opium. This is an important symptom. Chest emphysema, dilated heart width, grindtilia, already I told you. So if there is a cardiac symptoms in the later stage of the COPD, grindtilia is the medicine we can think about in the core pulmonary, and also in the cases of the right ventricular, right heart hypertrophy. Then Seneca is the salient features are cough and sneezing. That is important symptom. Asthmatic bronchitis in all people with chronic emphysema. There is bronchitis, asthma is there, chronic emphysema is there. Difficult raising of a tough profuse mucus in the aged. Usually Seneca is suitable for the bronchitis of the aged. Then rubrics of importance are cough, all people. Seneca 2 mark, and other medicines are all people. Umbra gracia, ammonium carb, antin tart, beretta cough, sorinum in the cancer repertory. Cough, sneezing, and Seneca is the only medicine given. Chest inflammation, bronchial tubes, Seneca 2 mark. The dosage which you can consider is tincture to 30th potency according to Boris Remediga. Then Scylla. The salient features are the valuable in chronic bronchitis of all people with mucus rails and dyspnea and scanty urine. Violent, furious, exhausting cough with a profuse mucus, salty, slimy expectoration. The taste is salty or slimy. Spurting of urine, that is important demarcating symptom. Of urine while coughing. What are the other medicines? Other medicines of spotting urine, bladder, urination, involuntary cough during the other medicines as Epis, Causticum, Netromur, Phosphorus, and Pulsatilla. Then it is a bronchitis medicine, chest inflammation, chronic bronchial tubes. Scylla is a 3 mark medicine. Then Drosera. This Drosera is also one of the medicines we can think in the acute exacerbation of the COPD cases. Spasmodic cough, like whooping cough with the paroxysm following each other very rapidly, can scarcely breathe, chokes, cough aggravation, warmth, lying down after midnight, drinking, laughing, singing, all these things are there. Cough begins as soon as head touches the pillow. What are the rubrics? Chest inflammation, bronchial tubes, Drosera 3 mark medicines. He is given as a 3 mark medicine. Chest inflammation, bronchial tube, all people, Drosera has got 2 marks. So aged bronchitis, this is one of the good medicine. And chest emphysema, Drosera is given with a 1 mark medicine. Then antin tart, what are the features? Cough appears to be large collection of mucus in the bronchi. That means bronchitis is there, much sputum is there. Great rattling with little expectoration, cough and dyspnea, amelioration lying on right side, amelioration after expectoration, eructation. Bronchial tubes are overloaded with mucus, coughing and gasping continuously, emphysema of the aged, antin tart, emphysema of the aged. Chest emphysema, antin tart is 3 mark in cancer repertory. Respiration, difficult mucus in trachea from antin tart, arsenicum, hypogenium, cactus and ipecac are the medicine. Chest inflammation, bronchial tubes, antin tart 3 mark. Usually, 2x, 3x, low potency medicines and are more suitable. Antim-Ars, salient features, one of the good medicine for emphysema with excessive dyspnea and cough, increased much secretion, cough and dyspnea aggravation, eating and lying down, affects preferably upper left lung, myocarditis and cardiac weakness. If the emphysema is complicated, the cardiac features are there, and we can think about the antim-Ars also. Swelling of foot and swelling around eyes due to heart problems. If there is pulmonary edema, pulmonary hypertension, and the core pulmonary, these features comes the swelling of foot and all. So those may at that time antim-Ars also can be useful. Chest emphysema as antim-Ars is 3 mark medicine. Respiration difficult, lying while antim-Ars is given in synthesis repertory. 3x2 and lower potencies can be more useful. Ammonium carb, one of the best medicine for emphysema as per the HCLN. In HCLN, only one medicine, it is written, with the emphysema, it is the ammonium carb. Dyspnea with palpitation, aggravation, exertion on ascending few steps, entering a warm room, cough dry from tickling in throat as from dusk every morning from 3 to 4 a.m. Early morning aggravation is a feature of ammonium carb, like Kali cough. Loses breath when falling asleep, must waken to get breath, like Grandilia and lacusis. And it is given pulmonary edema. So We have to think about if there is pulmonary hypertension, pulmonary edema and all, those may be ammonium carb can be thought of. Then in the rubrics, just emphysema, ammonium carb is 3-mark medicine. Respiratory and difficult emphysema, ammonium carb is given. And as per Boric, 6C is the best for general use. Even the lower potency medicines are more effective in COPD cases. Phalandrium aquaticum. Salient features are offensive expectoration and cough in bronchitis, emphysema and phthisis. Dyspnea and continuous cough early in the morning. Cough with profuse expectoration compels him to sit up. These are the features. Profuse expectoration is the main feature. Chest emphysema, phalandrium is phalandrium is the middle, so it's given in 2-mark. Expectoration order offensive, phalandrium 3-mark. That is purulent sputum. That is the feature of phalandrium. Then one medicine which is very useful is Pix liquida. Bronchial irritation after influenza. If there is an influenza attack and that will lead to triggering the COPD, the Pix liquida can be thought of. And the other medicines are creosotum and calibite. Chronic bronchitis rails through the lungs and mucopurulent sputum, offensive odor and taste. That is the feature of Pix liquida. Pain at a spot around the 3rd left costal cartilage when it joins the rib. That is the pain. Left costal cartilage, there will be pain. That is also a feature. The rubric is just inflammation bronchial tube. Pix liquida is given 1-mark medicine in synthesis repertory. Then arsenic album, everyone knows this is one of the best medicine. Shortness of breath, unable to lie down, must sit up, aggravation midnight, symptoms usually 1 to 2 to 12 to 2 a.m. aggravation, taking cold in midsummer. Emphysema is given in arsenic album. Pulmonary edema is also given. Rubrics are chest inflammation, bronchial tubes. Arsenic is the 3-mark medicine. Chest emphysema also in arsenic is a 2-mark medicine. 3rd to 30th potency is very high potency is often yield brilliant result. For the complete cure, we have to use the high potencies also. Blata orientalis, a remedy for asthma, especially when associated with bronchitis. Asthmatic bronchitis can be thought of ACOS, the condition asthma COPD syndrome. Indicated after arsenic album when it is insufficient. That is very important. When for a case with arsenic album, in between if there is a bouts of aggravations or acute asthmatic acute attacks of the dyspnea, this bladder can be thought of. Cough with dyspnea in bronchitis and phthisis acts best in stout and corpulent patients, much pus-like mucus. Chest inflammation bronchitis bladder is given 1-mark medicine in synthesis. Lowest potencies during an attack. After the spasm, for the remaining cough, use the higher. That is, for the acute attack, bladder tincture can be given, and after getting some relief, bladder 30 can be used. Carbovec, spasmodic cough, bluish face, offensive expectoration, breath cold, must be fanned, hoarseness, aggravation evening, breathing laborious, quick and short, worse walking, wants to take a deep breath. It's one of the brilliant medicine. It is a medicine for blue blotters because cyanosis is there. Chest emphysema, Carbovec, for emphysema conditions also Carbovec is good. Chest inflammation, all people, Carbovec is a 2-mark medicine. 30th potency and higher in chronic condition and in collapse. Next medicine is Calicarb, which is the complementary medicine of Carbovec. Bronchitis, the entire chest is very sensitive. Cough, dry, paroxysmal, loosens viscid mucus or pus, which must be swallowed. Spasmodic with gagging and vomiting. Leaning forward, release the chest symptoms. Chest inflammation, bronchial Calicarb is given in synthesis repertory. 30th and higher potencies, and do not repeat too often. That is the given in Boric. Choking cough, suffocating attacks, has to rise up and bend head backwards, troublesome when walking. And cough excited whenever any part of the body gets cold or uncovered or from eating anything cold. If the complaints aggravates during winter, this may Parsulf is one of the medicine which is very helpful. Chest inflammation, bronchial tubes, Parsulf, and chest emphysema, Parsulf is 3-mark medicine in cancer repertory. Ipecac is one of the medicine for acute attacks, cough, dry, spasmodic constrictors, dyspnea with anxiety about stomach, cough with the rattling of mucus in bronchi when inspiring like antin-tart, cough incessant and violent with every breath, dyspnea, constant constriction in the chest. The rubrics, chest inflammation, bronchial tubes, Ipecac is a 3-mark, and chest emphysema also is made there in the Ipecac is a 2-mark medicine. Chest inflammation, bronchial tubes, children, it's a medicine for bronchitis in children. If the COPD is children, this Ipecac is one of the medicine. The dose is 3 to 200 potency. Then bromium, fibrinous bronchitis, great dyspnea is emphysema. Bronchial tubes feels filled with smoke, spasmodic with rattling of mucus in larynx, suffocative. Dyspnea cannot inspire deep enough because due to emphysema, it is hyperinflated, cannot inspire deep enough, difficulty in getting air into the lungs. The medicine rubrics are chest emphysema, bromium is 2-mark medicine in cancer repertory. Respiration difficult, inspiration, bromium is there, and other medicines are causticum, sambucus, iodine, and phosphorus. Respiration difficult, smoke as from the bromium. Bromium is there, Paritaca, populus, and natromas are there. Then one medicine, the Maritamur is the medicine which is having the symptoms, bronchial affections of all people with cardiac dilatation. If there is a cardiac complication or core pulmonary, Maritamur, the medicine we can think about. Great accumulation and a rattling of mucus with a difficult expectoration. Leaning forward relieves chest symptoms. That is the main prescribing point. Leaning forward relieves the chest symptoms. Chest inflammation, bronchial tubes, Baritamur is as 1-mark medicine in cancer repertory. The dose is low potency. That is 3x BS repetition, so that we can repeat the medicine continuously. Then phosphorus is one of the best medicines. Hard, dry, tight, racking cough, bronchitis, congestion of lungs, cough, going from warm to cold air, reverse of bryonia, aggravation lying on left side. The whole body trembles with cough, tightness across chest, great weight on chest. Then rubrics of importance are phosphorus, respiration difficult lying on left side, and chest emphysema, phosphorus 2-mark, and chest inflammation, bronchial tube, that is bronchitis, phosphorus is a 3-mark medicine. These are the main common medicines which are very important. And I had skipped some common, some very bryonia and all, that all of you knows very well. So some rare medicines which is given in synthesis repertory. The indications of those medicines I had collected. One is Marubium vulgare. That is the medicine given for chronic bronchitis in synthesis repertory. The symptoms are bronchitis, relaxes smooth muscles of the bronchus and stimulates mucus production. It is not a well-proven drug, but in the Metrimedica, only says the symptom given is relaxed smooth muscles of bronchus, stimulates much production, mucus production. Then Myrtus Checan is a rare medicine. Chronic bronchitis with a dense alloyed sputum, difficult to detach, copious expectoration, keeps patient distressed and coughing. Myrtus Checan is given. Balsamum tolutanum, it is a good medicine. So I have used this medicine. Chronic bronchitis with profuse expectoration. So there will be profuse expectoration for the Balsamum tolutanum. Asclepias tuberosa is given. A respiration painful, especially at the base of the left lung. Usually affection is on the left side. Dry cough, throat constricted, chest pain, amelioration, bending forward. Then Hypocyanum. Hypocyanum is a 3-mark medicine given for the bronchitis and emphysema or aged. Bronchitis in the aged where the suffocative from excessive secretion is imminent. Hypocyanum is a very good medicine that can be used in 6th potency or 30th potency. It is very effective. Ammonium causticum is also a good medicine. Accumulation of mucus with incessant coughing, spasm, glottis, patient gasp with breath. That is the main symptom. There will be spasmodic cough, spasm of glottis, and this patient gasp for breath. Ammonium causticum in low potency is good. Tuca virosa is a rare medicine. Constant tickling, spasmodic cough, as if the chest would fly to pieces. That's bronchitis. Suffocating breathing from dropsy of the chest, hydrothorax. It is given. Hydrothorax is also given Tuca virosa. These are the few rare medicines given recently included in the synthesis repertory. So these medicines also can be tried for the COPD cases and chronic bronchitis and emphysema. Then we will go to the one case of COPD, which is treated by me. The case in a nutshell I am giving, because I am not giving in a structured manner. A 45-year-old male named Girish Kumar came to the dispensary with the current episode with the recurrent episodes of dyspnea, cough, and wheezing. He was having these symptoms when he came. On examination, he was having rhonchi crackles in all lung fields. He was having productive cough with a thick white or slightly alloyed sputum. Usually in the morning, I was a slight alloyed sputum, which was there off and on throughout the day, which aggravate while lying down and from fanning, exposure to cold, and he usually gets amelioration after the expectoration and after sitting up. These were the presenting symptoms he narrated when he came to me. Then what are the other history of presenting complaints? What are the past histories? Complaints had started 5 to 6 years back, actually. He was suffering, he was having the recurrent bouts of this suffering for the last 5 to 6 years. He gets similar episodes of respiratory distress 3 to 4 times every year, which lasts for 3 to 4 weeks. That is there, because his complaints usually comes many times in a year. Attack starts usually during change of season, during polluted atmosphere, exposure to irritant smoke, and it will not go off without using antibiotics and bronchodilators. He's a resident of Delhi, and he's staying in Delhi, and the pollution and the low air quality level are there in Delhi, and his attacks starts usually during the change of season, during polluted atmosphere, exposure to irritant smoke, and it will not go off without using antibiotics and bronchodilators usually. He is having a history of seasonal allergic rhinitis, which triggers his condition. Then he was very much concerned about the recovery of his illness because of its recurrent nature and the family history of lung cancer. That was the main mental feature which I noted. So when he came, he was constantly saying that whether I will recover from this disease. That was the concern he was arising, because his father was having lung cancer, and he died around 3 to 4 years back. 4 years back, actually. Because of that, he was in a very he was in a worried. He was a worried person because of that. He was very much concerned about the recovery from these recurrent attacks. His father died of adenocarcinoma of lung 4 years back. His mother is diabetic since last 25 years. While taking the case, he explained that his thirst is very much increased. That was the physical general. The thirst was very much increased. He doesn't like sweets much. There was aversion to sweets. It's more comfortable during summer, as his complaints aggravated during other climates. His complaints were very less during the summer, and it usually triggers during the winter season. This is the nutshell of the case. He came many times to me. And which medicines you are thinking about?
Dear participants, if you have any suggestions, you can put in the chat box.
Okay.
Till now, we have only arsenic album.
Anyhow, so I will tell the medicine part later. The repertorization part. So what are the medicines? So what are the rubrics I have selected? So medicine. Mind rubric I selected mind, despair, recovery of from synthesis repertory. The generalities: food, sweets, aversion, because patient was having aversion to sweets, that was very prominent. And stomach thirst, unquenchable. Thirst was very much increased, so that rubric I take. Respiration impeded, obstructed, because there was a obstructed feeling in the chest and constant wheezing was there. So this rubric taken. And respiration difficult, lying down. Chest inflammation, bronchial tubes, bronchitis. These are the 6 rubrics taken for the repertorization. And these are the medicines which came. Arsenic album, anyhow, arsenic album came in the, as the prominent medicine with this 16 out of 6. Phosphorus 12 out of 6, for Marsol 12 out of 6, sulfur 11 out of 6, the calcarea carbs 10 out of 6, and natramor 8 out of 6. These are the medicines after repertorization. Anyhow, before going to the details of the prescriptions and all, I will play the testimony of that patient. He had given a video clip to me because they just hear what he is saying about his disease.
Namaste, I'm Girish, a Delhi resident for the last 16 years. I've been suffering from allergic rhinitis, and every episode of this rhinitis would eventually end up with a chest infection, with a lot of phlegm, cough, breathlessness, and wheezing. I took allopathic medication for the last few years for my severe allergic bronchitis. I also briefly switched to Ayurveda for a short period. In 2017, my health deteriorated and I was repeatedly falling sick every 2 to 3 months. I was on continuous antibiotics and steroid inhalers along with other medication. I had disturbed sleep, exhausted mornings. Overall, my health condition and the quality of life was severely impacted. In December 2017, I consulted Dr. Jithesh and I started my homeopathic medication. And I've been continuously using homeopathic medication since then. I would like to happily admit that my health condition today has overall improved. And I would also like to say that I have not been using my steroids or any other antibiotics for any chest-related ailment. Thank you so much, Dr. Jithesh. Namaste. Namaste.
That was the testimony of the patient. He is still coming to me. Very rarely is coming because of his complaints. Anyhow, what are the medicines given? The medicine I selected was arsenic album itself, because the majority of the symptoms was covered by the arsenic. And after repertorization also, the arsenic was the most prominent medicine. But there are certain things, certain important points. So we had to, I had to point out. The first one is arsenic album 6 or 30C were the most effective medicines for these patients. During the treatment, I have given many times arsenic and 6 and 30 during his acute exacerbations. Try to increase this potency, because I had tried, because after getting some relief from arsenic 6 then to 30, usually what we'll give, this may will go for 200 potency. This may if the complaints recurs. But you should, as for this patient, this may I didn't get much relief from 200 or 1 or any other potency. And again, mothers may if there is a aggravation of the symptoms, I usually gives again the 30th potency or 6th potency, then he gets relief. That was the feature of this case. And then during every episode of attacks, he gets relief from arsenic 6 and 30. Phosphorus was tried once, as it is the second best medicine coming after repertorization, and also the complementary medicine of arsenic album, but there was no relief. Phosphorus was the second best medicine with 12 marks. And also phosphorus is one of the complementary medicine of arsenic. So I selected phosphorus as well in between, as he was not completely recovering from the disease. I had tried phosphorus also in between, but with very little relief. Very rarely I used bladder tincture and granula tincture to control severe bouts. In the initial stage, but earlier he was using the bronchodilators and steroids and also those there were during the acute attacks. Those sometimes if they're very severe attacks, so bladder tincture and granula tincture also given in between for getting some control. So natrum sulf 6X was also used to control productive cough. That was also very effective. Why selected natrum sulf? Because natrum sulf is the complementary of arsenic. So there is some good action between arsenic and natrum sulf. Frequency and intensity of respiratory distress decreased gradually. So he's the patient since December 2017. But initially he was coming to me many times, around 3 to 4 times in a year. But gradually it reduced. The attacks got reduced. The frequency and intensity of the respiratory distress decreased gradually. Patient has not used any allopathy medication for the last 2.5 years. There is not bouts of attacks since because the last 6 months he is free of the complaints, but still I am expecting some problems in the coming winter, because there is a chance of aggravation, because he is still living in Delhi, because he is working in Delhi, and he is because of the pollution, the air pollution and all, he is getting the triggering during the winter. But last winter he was almost his complaints was not that much very severe. Anyhow, for the last 6 months, he is free of the disease. Anyway, arsenic is the exact medicine for this case. What is the point to ponder? Migrating from Delhi to less polluted place may help him to achieve the complete recovery. Many times I had advised him to leave Delhi and to get jobs to some other less polluted city. Even he is planning for to migrate to the Hyderabad and all, but still because of his job and all concerns, he is living in Delhi only, and his children are studying here only. So it is a case, it is a clear-cut case of the COPD. And so this is any doubts about this case or any questions regarding the presentation and all, you can ask to me.
Doctor, I think the session is itself well explanatory, but in the case, participants, if you have any doubts, you can ask in the chat box. Doctor, we have question. Please suggest a role of LM potency in COPD cases.
So far, I'm very frank, so far I haven't used any LM potency for the COPD cases. Okay. Because usually I use the centesimal scale only. And the availability of medicine also is a problem in Delhi. So usually we are getting good results from 6C, 30C, and even the tinctures also for the acute bouts of attacks. Anyhow, I will try LM potency in my later cases.
Of course, doctor. Okay. And doctor, people are asking about like a 3 mark or 2 mark. What is this?
3 mark means the higher grades. 3 mark means with the top grade medicines. Bold letter medicine in the repertory is 3 mark, and 2 mark is italic medicines, and 1 mark is the non-italic medicines represented in the repertory.
Okay, doctor. And they are asking about the repetition of mother's tincture in the case, and also wants to know what is mother's tincture.
Repetition, mother tincture actually. Mother tinctures is usually during the acute attacks, actually, in the where there is an acute exacerbation of the conditions. तो उसमें to reduce the spasms or wheezing और उसमें वो जो productive cough I used Blatta and Grantilia in between. Blatta is a complementary medicine for arsenicum actually. And Grantilia is very good for this distress in the night and waking up at night. So I had tried Blatta and Grantilia. It's not together. In different situations, I had given Blatta and Grantilia in this case. But it was very effective.
Okay. And scope and limitations in COVID cases affecting the lungs.
Scope and limitations of COVID case. So actually, the symptoms usually we get in the breathlessness and all in the starting stage, and it will lead to gradually the patient will lead to the pneumonia at stages, and the patient needs some ventilatory support and all. The main medicines which comes for the COVID cases which we are treating in Delhi, because we are having so many cases here. And my colleagues are also treating, and even I had treated around 20 cases. Those main medicines comes are the arsenic album, gelsemium, bryonia, and pulsatilla. And less frequently, it's magnesia more, or China and camphor are coming. So the top medicines are arsenic album and bryonia. So bryonia is having dry cough and less productive cough, and also arsenic is majority of the symptoms are covered by the arsenic, and also in certain cases by bryonia. But in certain persons with a very high weakness and prostration and all, and with chilliness and all, so gelsemium is also good. And if there is anosmia is one of the features of during the initial stage of the COVID cases. So then the magnesium more and pulsatilla are the medicines given. So that works very well. If there is an anosmia and also loss of taste. So anorexia, this may lots of taste I'm saying, this may then the arsenic and not pulsatilla and magnesium more are the medicines. So this is the experience in Delhi.
Okay, doctor. Then we can take one more question. Chronic asthma from dust, those who are using steroids and bronchodilators.
Chronic asthma from dust for those who are using bronchodilators and
Steroids.
steroid. So actually, we cannot withdraw the steroid and bronchodilators as in a stretch. Actually, we have to taper the dose actually initially. The for the dust aggravation, there are so many medicines are there. One of the mother tincture or in low potency also we can use. It is pothos fetidus. That is the main medicine, asthma aggravation from the dust. It is given. But for other medicines which is useful are usually allium cepa, arsenic album, grantilia, Aralia racemosa. These are the other medicines we can think of. Otherwise, the constitutional medicines has to be tried, because after taking the complete case, we will get some other polygraph medicines also. But for acute attacks, pothos is a very good, very wonderful medicine.
Okay, doctor. I think we have covered all of them. And should we conclude, doctor?
Okay, sure.
I think we are running out of time. And we have taken almost all doubts. So participants. Okay, Dr. Deepu, can we conclude, doctor?
No. We can. I think we can conclude the session, sir. That's very informative.
Okay.
So, Dr. Anupriya, you please say the official word. Okay.
Yeah, sir, as all the time, it was very informative session, and Dr. Jithesh's session was the most popular. I think it was awesome session with the accurate statistical data and deep pathology. So thank you so much, sir. And we are very pleased to have you here, and it's our privilege to listen you and share your all experiences. And thank you so much, sir. And we expect more sessions from you, from IHMA family. I show my heartily gratitude. Thank you so much.
Thank you, Anupriya. Thank you, Deepu, and for all the IHMA faculty and SMO and all the doctors. for listening to me for the last 2 hours. Anyhow, it is a good opportunity for me, and it was a very nice experience for me. Thank you all.
Thank you, Doctor.
Okay, okay then. Okay.